Yeah, listen, Tom, I'm telling you, it's gonna be fine. Just throw long over the middle to Grabowski. Just throw the damn thing long. Okay? It'll be great. Oh, hey, what's happening? I was just giving some last minute instructions to Tom Brady about how to beat Kansas City. So I actually supposed to have my hat here this week. So I left my hat home, my New England Patriots hat. But I'll bring it next week before the Super Bowl, in 2 weeks. Anyway, welcome everybody to Facebook Live. And today's 17th of January. I don't know where you are, but Baltimore is somewhat cold. It's supposed to snow, the usual nonsense. So we picked the topic today, trauma, and I just thought trauma is one of the most common things everybody does, ER setting, and just a few points about trauma. Sometimes we get questions on CTisus about that, so I thought I would go through it. Also, it gives me, as I mentioned, questions. I'm getting told to remind everybody that we have a new Ask the Fish thing on CTisus. It's really nicely done. You can put pictures there, you can ask questions, you can discuss things. It's really very slick, and it went live on January 1st. It's only been around for less than 3 weeks, and it's starting to get used, but it's probably a very good way we've been doing the Ask the Fish for many years. The other system was okay. It's somewhat exceedingly difficult both for people to put questions at times. You surely couldn't put images, and then for me to answer them was somewhat challenging. But this works really well. It's really nice, very clean looking. And hopefully, if you have questions, you'll put the questions down. If I can answer them, I'll answer them. If I can't answer them, I'll find someone else who can answer them. So, trauma. So questions always become in terms of protocoling. Questions are, A, do you do a non-contrast scan? So we're talking about thoracic and abdominal injury. We do not do a non-contrast scan. Sometimes people have said, well, if you're worrying about aortic injury, would it be helpful if you were doing a non-contrast scan first? I guess theoretically you can see blood easier on a non-contrast CT when it's minimal around the aorta without contrast than with contrast at times. But the fact is, doing a good injection, you're not going to miss a site of trauma. So we don't do non-contrast CTs. It increases the radiation dose, but also just delays the study, and time is of the essence when you're doing a trauma patient. So then the question is, what phases do you do? Do you do multiple phases? So obviously, you're going to be doing an arterial phase. So whether you're doing from diaphragm, for abdominal, or maybe lower, do a runoff, or if you're doing a thoracic and an abdominal CT patient with MVA where you're not really sure where you're looking, arterial phase works very nicely. All of the things in terms of vascular injury are really well defined. Sites of bleeding, particularly as it relates to penetrating trauma, whether it's gunshot wound or stab wound, are really shown well on arterial phase imaging. You also get a good look at the function, liver, spleen, kidneys, bowel. You look at things like the adrenals. Is there adrenal hemorrhage? But also, are there very bright adrenals in a patient who's hypotensive? So the arterial phase works really well. But then you say, is the arterial phase enough? Should you have a second phase? Now, going back on the arterial, one other thing that's important, because sometimes people would argue about doing arterial, it's been shown that splenic artery bleeding and decisions whether to manage conservatively or with surgery are best defined from the arterial phase. Active bleeding on arterial phase makes it more likely that the patient will end up getting a splenectomy or partial splenectomy. So I think it's really good to have. Now the question is, what about venous phase? Now in the chest, probably if you had only one phase and you're looking at vascular injury, it's going to be enough. Sometimes with bleeds, you may only see them, or you may see them better on venous phase imaging. So that might be one reason people think about venous phase. In the abdomen, venous phase is a thought for that same reason. Sometimes the bleeds, you just don't pick them up as well on arterial. You probably always will see them, but you see them better on venous. You know, it's a thing we talk about when we look at GI bleeding in the bowel, right? Arterial and venous both can see them. Sometimes one is better than the other, but it's the transition between the two that makes detection a whole lot easier. The other thing that comes up in terms of abdominal imaging in trauma patients is, should you get routinely excretory phase imaging? And it's really a good question, because if you're worrying about kidney injury, arterial phase is really good for looking at lacerations. Arterial phase is really good for looking at perfusion changes, perhaps. But excretory phase imaging is very good for looking at excretion of contrast. And so perhaps if you had the pelvis or the ureter injured, would it be better to have delayed phase imaging? A lot of people do get it, and it can be helpful, though I think most of the time you can make the diagnosis, or at least suspect the diagnosis, based on the arterial phase imaging. If somebody has an injury to the renal pelvis or proximal ureter, they're not going to have normal renal function. There's going to be perfusion changes. There may be a laceration. There's something that's not going to be exactly right. And so in those cases, delayed phase is really good. I think routinely getting delayed phase is somewhat controversial. We have not done that. Some places do that. It keeps the patient on the table 5 to 10 minutes longer. Particularly if you're trying to get the bladder distended, it just may not be worthwhile. Now, obviously, you say, what about bladder injury? Well, if you were worried about bladder trauma, let's say you had pelvic fractures, that's the most common thing associated with bladder injury. We know that if you give IV contrast and then you wait for excretion of contrast into the bladder, you can miss more than half of all bladder perforations, because to see a bladder perforation, you need to do CT cystography. So if you're worrying about a bladder injury, maybe you scan the patient, you see multiple pelvic fractures, and you see blood in the pelvis. And yes, I know the blood can be due to the pelvic fractures, but perhaps you're worrying about bladder injury. Bladder's displaced, bladder just doesn't look as well maybe, or as distended as it should. You need to do a CT cystogram. CT cystogram, your accuracy is basically 100% for looking whether it's intraperitoneal or extraperitoneal bladder injury, whether it's the base of the bladder or the dome of the bladder, doesn't matter. So if you're thinking and worrying about bladder injury, just getting 10-minute delays, or some people get 15-minute delays, is not going to help you, because contrast layers out and it's not going to be extravasating. You'll miss most of the injuries of the bladder. So if the clinicians are suspicious, based on mode of injury, if you're suspicious based on the imaging, just do a CT cystogram. So patients always have Foley's in place anyway. What we do for a CT cystogram, under gravity, we drip in 500 cc's of contrast, and the mixture is 500 cc's of saline and 30 cc's of contrast, Omni 350. That works really nicely. It's good opacification, but it's no artifact off it, so it's not too dense. When there's extravasation, be it intraperitoneal, extraperitoneal, or both, you're going to see it very nicely. So I think that works out really well. Other questions in terms of injury: what about liver? What about spleen? I think one thing people comment on, perhaps, if you only have very early phase imaging, you get a moire pattern in the spleen. Sometimes people overcall that as injury. There's a concern sometimes if a moire pattern, perhaps you'll miss a subtle splenic laceration. I don't think that's really an issue, particularly if you look at the coronals. But again, maybe that's the scenario where a venous phase or a second phase will be helpful. So some places, some trauma centers now are routinely doing the arterials, and they're coming back at about 2 minutes. And you're not going to see a lot of excretion of contrast. You may see some, but you get rid of a lot of the pseudo lesions, and some of the findings may be simpler to do. So that's not necessarily a bad thing. Now, once you have the data, I think it's important to look at the data. Obviously, you look at axials, but it's critical to look at coronals and sagittals. One simple thing about the sagittal is look at the spine. Remember, trauma, you always worry about spinal injury. And we've shown that if you only look at the axial, you'll miss 80% of spinal injuries. So you really need to make certain you look at the sagittal, looking at the vertebral body height. Collapsed vertebral bodies are going to be missed very simply. You want to look at the sagittals, looking at the spinous processes, transverse processes. You want to be looking at everything. You can do a 3D volume rendering and just rotate the images around. However you do it, probably doesn't matter, but you need to do it. And as I say, at a minimal, be looking at sagittal and truthfully look at the coronal as well. So that becomes very critical. We know that common errors in trauma are bony injuries. So, for example, sternal fractures are commonly missed in sternal fracture, particularly when there's no real displacement or missed. When you have sternal injury, then you worry more commonly about aortic injury, because it's hard to get a real aortic trauma without sternal fracture. You can, but when you see a sternal fracture, then perhaps you're going to pay more attention to the aorta for any subtleties. So that's definitely an important thing. I think also in terms of imaging, we routinely will do 3D mapping, so you get a good vascular map, you get a good look at the various organs, you want to look carefully at the pancreas, you want to also be careful to look at the edges of the film, as we would say, look for the presence of any soft tissue injury. Sometimes patients get seatbelt injuries, then subsequent they have duodenal trauma. Well, you can look at the images and see in the soft tissues, if you see increased density in the soft tissue at some point, you want to say this patient probably had significant trauma. Then you look super carefully, particularly if you miss things the first time, at that region and make sure you're not missing anything. Things you can miss very easily: pancreatic injury, particularly pancreatic transections or small lacerations. Sometimes when it's a big laceration, of course, then you have perfusion changes, normal perfusion versus decreased perfusion. But if you only have partial lacerations or parenchymal injury, you may not see a whole lot of anything if you're not careful. So really looking at the pancreas carefully is critical on every case. And remember, pancreatic transection becomes very important to do early treatment before you're not able to put the duct together and the patient's pancreas basically atrophies distally. So we do look carefully at that. So that becomes very important. Let me just look at the screen here for a second. One thing is we appreciate the people on Instagram, but I can't see questions on Instagram. I can see comments on the Facebook side of things. So I'll say hi to Lydiana, who's in Palo Alto now these days. And I'll say hi to John Biacchino, who's in Mays Chapel, which sounds almost as far away as Jose Basilio, who's from Lima, Peru. So just for you people who don't know, Mays Chapel is like 25 minutes from Hopkins. It's in Timonium, one of the great hubs of the universe, Timonium, Maryland. And the other thing they're famous for, they have the Maryland Fair there, the Maryland State Fair, every Labor Day weekend. It's one of the worst fairs in history. I would not go on those rides there. Those rides are basically broken. They're about to fall down. You know, people go on those rides. They're a bunch of crazy people. That's also, I think, they discovered that if you deep fry Oreo cookies or something, I think it's Oreo cookies. I think if you deep fry anything, it probably tastes good, perhaps, if you like fried food. But I think they deep fry Oreo cookies or something. It's called something. I can't remember what it's called. Let's see what else. Head trauma. I think for head trauma, again, depends what you're really looking for. But again, critical things there. Non-contrast, people will commonly do non-contrast first, and then they'll do with contrast. You want to make sure you look at everything from the vessels, from the carotids. You want to make sure you look very carefully at the facial bones, mandible. I think 3D works really well, particularly for staging, defining extent of mandibular fractures, orbital fractures, and the like. Let's see, we're trying to get the furthest person. We have someone saying hello from Italy and Sarajevo, Bosnia and Herzegovina. That I know is far away, and I think the Olympics were there once, right? So we appreciate everyone from there as well. So we'll say hi. In terms of these pan scans now for trauma, there's been a lot written. For University of Maryland across town has written a bunch about it. How in trauma centers, to really expedite the process, patients get scans from the top of their heads to their feet. These complicated traumas. Again, they'll do non-contrast head, then contrast straight down through the lower extremities. We do a lot of lower extremities, gunshot wounds, stab wounds, bad fractures, and MVAs. There, dual energy works very nicely because you want to do bone removal to look at the vessels. Obviously, the fractures, the femurs, the tibias, fibulas, whatever, are often obvious from plain film or any other study you would do. And it's really the ability to look at the vessels and look for vascular injury, dissection, transection, occlusion, active bleeding. And that's often best done when you remove the bone. And we've published about that in the past. Jan Fritz has lectured about that. in the past. And so if you have dual energy is a good thing to do for lower extremities or even upper extremities. Some people do dual energy for everything, the entire scan, and then subtract stuff out. That's not an unreasonable technique. Also for trauma, we try to be careful in terms of radiation dose. Sometimes patients are younger, so dose is even more important. So you want to be careful that you're giving the patient the right dose. Make sure on your scanners you have that built in, and perhaps build it into patient size. Remember, the ER setting, these pan scans for trauma, you have very little time to react. Basically ER saying the patient's here, you do the study. You need to have those protocols really very well designed. So let me see, any other questions? Will AI replace radiologists? That's not my talk for today, but the answer is yep. We're all toast and crackers, that's it. So goodbye, good luck, we're out of here. No, I think what it's going to do in the long haul, it's more than 10 years, is change the role of radiology. I think radiologists are going to have to adapt to be more consultants than just reading films, because the computers will help you read films faster, which means we'll probably get paid less. You'll also be surrounded with more information. So what radiology needs to do is be strong and be aggressive and be like the master of their domain, not to steal that from Seinfeld, but you need to figure out a way of how do you control the information, because if AI gets real good, then maybe a surgeon can say, I'm the master of the domain, everything comes to me, I decide what to do. Radiology needs to be very aggressive in defining our role within that process. I think some parts of radiology, mammo, would be replaced much faster, but the mammographers could do more biopsies or do other things. But I think it's definitely coming. CTisus, the website, we have a whole section on AI. You can read about it there. We have a lot of articles, a lot of lectures, stuff from NVIDIA, other sources of information. So we're trying to keep people up to date on the rapid changing. I guess, let's see what else. What are my thoughts about the dual? I guess it must be dual source. I think dual source is very good for bone removal, things like that. I don't think the routine use of dual source is that good. The images, for example, of the pancreas, I think are far inferior to the things I can create without dual source imaging. So that's not an issue. Let's see what else. We got visitors from the Ukraine and Paris, Albania. That's a lot of places. Don't make me put I could do a thing where I have a map and I put pins in, but I probably wouldn't be as good as I used to. I kind of, in my mind, everything now is like the old posters you saw. There's a thing that shows New York, and then it shows the Pacific Ocean. Everything else is flat, and going right, I think it has London, Paris, and the Kremlin, and the rest is flat. So I'm better than that, but I'll leave it to AI. So I think we're out of time. If you have any questions, you can put them on Facebook. If you have any questions, you could put them on CTisus on our new quiz section. And if you have any questions, who's going to win Sunday? It's the Patriots. And again, we'll see you next week. And we'll see if we're right. Have a great day.